pleasure to be here. Thank you, Dr. Schertz, for inviting me, and it's good to see familiar faces. I guess, given the introduction, I will say that some of what you'll hear today in terms of how I've evolved over the last 20 plus 30 years, maybe, right, Dan's responsible for. So we all, as mentors, we give to our students, but we also take from our students as well. Okay, so I'm going to talk about pathology education. I'm going to tell you 3 stories. The first story I'm going to tell you is in my capacity as department chair, and it's going to be about our residency program and how we're evolving our residency program and where I think pathology needs to go, where pathologists need to go in practicing 21st century medicine. The second I'm going to tell you about is in my role as a CAP governor and the chair of the Council on Education. And here I welcome any feedback today and after today for educational programs you think that we need. I know that there are at least 18 pathology societies, and there's great education coming from many of those societies. Unfortunately, I'm only familiar with this one, so it's not a bias. It's only a bias in the knowledge I have, not what I think you should, where you should be going for your education. And any input you want to give me as to what we should be developing, please feel free to reach out to me. And then the third story I'm going to tell you about comes from as I chair the Committee on Undergraduate Medical Education and work with the UMEDS group as part of the APC, and Mara Rendi has been very involved in this project. The idea started several years ago, and I'll tell you about that when I get to that part of the talk. I've given you educational objectives on these 3 areas. One is how we transition our residents from medical school into residency, then where our program is going in training residents. Point number 3 is evaluating personal choices in education for maintenance of certification, and the 4th is on medical school education. So our residency program is structured like many, where we have a program director with an administrative assistant who takes care of the residents and interacts with the residents. We then have AP and CP associate directors. J.J. Steinberg is the director. Tiffany A. Bear is the AP associate director. And Jim Fay is the CP associate director. And then we have a larger group. This group meets as a so-called Harmony group to review policies and program on a monthly basis. We have a residency advisory committee. This committee then extends out to faculty and residents, where we and serves as our program evaluation and clinical competency committee. We have chief residents. We have 3 chief residents that work both in the operations part of the program and the medical school education part of the program. And I meet with the chief residents on a monthly basis as a sort of a management course, if you will. Then we have a mentoring program, a director of mentoring, and the visiting professor program. The residents choose 6 visiting professors, and that's their choice, their day with the visiting professor, and they go to dinner with the visiting professor. And even when they're faculty choices, the residents spend significant time with the visiting professor and going to dinner with them. And that is basically to get the residents connected to the rest of the world and job potentials for the future. So how do we recruit our residents? We used to be open to whenever the resident candidates were available to come. And that was a nightmare. Several years ago, we decided we would do 3 recruitment days, 1 Saturday, 1 Sunday, and 1 weekday. Our program director triages the applications. We get several hundred applications. We bring in approximately 75 candidates, about 25 per day. give an overview to the candidates. We have 3 people interview the candidates. We have tours, we have lunch. Then we kick them out and tell them they should go visit great places in the Bronx and the rest of New York. And then we sit down as a group and we rate them. And we rate them in a stoplight type fashion: green, yellow, red. The first rating, right after we've all met them, three people will give their review, and then we'll have discussions of those who've interacted with them during a meal or during a tour. And the main purpose here is just to put them in the categories. Probably the most important category is the red category. That person we don't ever want to see again, okay, because we don't want to spend any more time on that candidate. Occasionally, people were so taken with a resident that green wasn't high enough, so we created the blue, sky blue category, and we have maybe 10 that fall into that category. So then we do that 3 times, and then we put the 3 ratings together, and I sit down with the associate directors and the director and review that list. But the Residency Advisory Committee, which includes residents as well, also reviews that list, and that's our match list that just went in today. Now, I'll say during the interview and the rating process, the residents have a full vote. It's not unusual that I will have interacted with a candidate who's very bright and very aggressive, and I think, wow, this person is terrific. And then a resident, not to be gender specific, but usually a female resident, will say of a male candidate, gee, you know, if you bring this person in, I'm not sure I can stay here. Because there are things that come out in the social setting, in the tours and what have you. And any thoughts on where that candidate goes? Any thoughts? Color?
Red.
Red, right away. Because my interactions with the residents are minimal, and the resident interactions, and to be fair, usually it's not a gender-specific situation. Those individuals who behave that way or seem to be troublesome are ferreted out pretty early on, and we put them in the red category because they're just going to be disruptive. And we're not perfect. We make mistakes, but having someone who's disruptive to the program is not good for anyone. So we have all these scoring criteria. We have criteria that look at their letters, that look at their boards, the scores, the exam scores they've taken, and all this stuff. But in fact, one of the most important types of things we do are behavioral interviews. And we try and teach everyone how to do a behavioral interview. This is a 5-point factor looking at different personality types. I've blocked out 3 of them because the 2 we focus on are conscientiousness and agreeableness. And that is, we want someone with a good work ethic, and we want someone who gets along with others. And so this slide and this slide are for your reference. I don't expect you to read this. I know it's a problem when someone says that, you'll start reading it. But basically, we want to know, why did you go into pathology? Why did you pick that? And what has motivated you? Have you ever worked in a team before? If you've worked in a team, did you ever have any problems? Did someone not pull their weight? If they didn't pull their weight, what did you do about it? And so on. And we try and get what drives someone, how committed they are to a career in pathology, and how well they work with others. In doing this, we've had pretty good insight into the residents that we've interviewed and the residents we've selected. Once again, are we perfect? No. But I think we've identified some people that we definitely don't want in our program. And for now, that's probably as good as we can do. Of the residents that the candidates that we interview, what we find from the intellectual and capability capacity is that if we're ranking, if we'll put 50 people, 40 to 50 people on our match list for 5 positions, because our residency director is a strong believer it should be 10 to 1 and he won't hear anything otherwise, so that's what we do. There's no one on that list that we wouldn't have in our program. So no one makes it to the list that we think shouldn't be there, okay? And we really usually go down maybe to the mid-20s or so to fill in our slots. Okay, so now we've selected the residents and we want to onboard them. So these are the residents that have come through the match. We onboard them at the end of May. We've run this program for 2 or 3 years now. The first year, we sent out a USB stick with the onboarding program, and I'll show you one of our residents developed a website to do the onboarding, and I'll show you exactly what's on that and show you the website in a minute. This onboarding welcomes them to the program. It tells them about the program. It tells them about the area. But it also tries to level the playing field and get some basic knowledge and information to the residents before day 1. And this is basically a normal histology review and some cases that will drive home points in AP and CP as listed here. We do this because medical schools don't. It's not, we don't take it personally. Medical schools don't do this for any residency program. It's not just pathology. We believe that they should, but they don't, so we do. And this is what the web page looks like for the online onboarding. And I'll take you to the site in a minute. This is another slide not to read. This may be a Coles to Newcastle kind of slide for you all. I'm not competent to build a site like that, but I felt that showing you a site that I couldn't tell you how to build was password protected really didn't do much for you. So the person, Dr. James Zismansky, who was a resident and built this site, I asked him to go through and give us a step-by-step how he built our site. So there it is, and you have it as a reference. On this site, we use the set of histology reviews by Dr. Minersik. We got his permission to do this. We did not use all of the tutorials that he had. We thought that would overwhelm the residents in this 1-month period, so we selected 8 that were, we felt, the most common tissues that one might see in AP. And then we built cases that, that reviewed some of the basics in terms of pre-analytic, analytic, and post-analytic variables. And we used learning objectives, and I'll show you the importance of that in a metric that we had later, and key points that they should learn. So this is our onboarding site live. This is the home page. If we go to the view the modules, these are the histology reviews we selected. This is the histology of the lymph node.
Here is some more lymphoid tissue. In fact, it looks like it's
These are 2 to 3 minute videos as a review.
Organ.
So it makes it,
it is the most classical picture.
I apologize to the residents in the room, but this is probably the attention span, certainly for me and maybe for your age group, of 2 to 3 minutes. And we are thanked. You're smiling, that's good. The residents, when they come in, thank us for this. And it really, they all do the review and they all do the test, which is an open book test. Yes?
So they do this review before day 1 or on day 1? Or
they get this in May. So they start July 1st. They do this before they start. So in my usual way, I wanted to better be careful because I'm being videotaped here. I wanted to suggest strongly that if they didn't do this and pass the test, they couldn't start. Now, obviously, I can't do that, but it's an open book test, and if they go through the exercises and just look at it and take the test, because the questions are taken right from these pictures, right? It really, what I'm trying to do is force them to actually do the work and go through it. And they all do it, and they all appreciate it, and they think it's great. So we actually have there's a new journal called Academic Pathology that's an APC journal. It's online. The publisher is Sage, and there's a paper that should be coming out on our onboarding process that goes over this. Okay, so that was, go back here. And then if we go to the case studies, the first one, just like the slide I show, has learning objectives, and then you can go right through the case. In addition, we want to welcome them. So we've developed the onboarding as onboarding plans are developed in industry, right, in other business sectors. You want to make you want to let people know what they're going to be doing. So there's a calendar, and so here's the calendar. This gives them their schedule for July, for the month of July and the month of August, as to what they'll be doing. There are frequently asked questions and answers to those questions, and there are resources for them as well, just to let them accommodate, to let them get acculturated to the Montefiore system and to the Bronx and all the great things that they can do in New York and in our system. Okay, they're onboarded. What do we do next? Next, we provide them with a 1-month boot camp. And in the boot camp, we give them a pre-test to see what they know, and at the end, we'll give them a post-test. We used to do a lot of didactic types of lectures. We always have a dynamic process to get feedback from the residents. We've limited the number of lectures now and do more hands-on teaching, contextual teaching. I want you to just focus on what's highlighted here. Once again, the additional words are for your reference later. We introduce them to grossing techniques, basic histology, the general approach to the glass slide, autopsy. Most of our residents come in as AP, all of our residents come in as AP-CP. Rarely a resident will go CP only. All residents get AP and CP rotations during their first year. The autopsy, we're trying to teach our residents to be pathologists, to be physicians. And the autopsy is one place where you start from the beginning with the clinical history and work it all the way through, looking at all of the data, clinical data, morphologic data, et cetera, to render a diagnostic opinion. So we feel it's important, that's an important teaching element. It's not how many autopsies you do, it's how you learn to do an autopsy and what you learn from that autopsy procedure. We then give them issues on quality control, quality assurance, looking at the variables at each stage of analysis, and informatics, some basic informatics and research opportunities. All the residents, we feel that our residents need to learn how to practice as an integral member of the healthcare team. And so they go through the first month as a team, working with each other and interacting with each other. CLG project. CLG is clinical looking glass. It was developed, it's now licensed and available to everyone. It was developed by Ron Bellin at Montefiore. And it's a method of doing longitudinal studies, basically. So we have 20 years of laboratory clinical data in the Montefiore database, and one can ask questions of that database to get to find out if there are ways that we can use diagnostic testing, treatment plans, et cetera. It's evidence-based medicine, if you will. It's the way Montefiore has been the leading pioneer ACO, and that system was used with the first cohort of ACO patients, full capitation, to say, of those patients, who used the most resources in the hospital? We found that 20% of the patients used 80% of the resources in that cohort. Of no surprise, these are patients with diabetes, with congestive heart failure. And so now you can manage the care, you can actually really manage the care, not costs, of those individuals, keeping them in compliance, keeping them healthy, keeping them out of the clinics and out of the hospitals. We train we feel that our pathology residents should learn data analytics, they should learn computational pathology, they should be asking questions when they go through the laboratories, be it in anatomic or clinical pathology, and trying to improve diagnostic medicine and working within the healthcare team. This boot camp process we do, it's dynamic, we interact with the residents, we get feedback, we test all the time. So how does this work? In 2013, we did a pre-test and we got an overall score of 56% and a post-test of 68%. And we said, we spent a month teaching them, and that's a pretty low yield. What are we doing wrong? And we had much more in the way of didactics. And some of us started looking and saying, well, what are we actually teaching? So in the CP part of the course, we found that the directors were actually trying to squeeze the full rotation of information into that introductory period, right? And this is where we went back to basics on learning objectives and saying to ourselves, what we're really trying to do is give a foundation of knowledge and skill sets to our residents that they can use for the next 4 years. So let's pick one example in any particular discipline and give fundamental knowledge and a process to making a diagnosis and then go forward. And have learning objectives, tell the residents what we're trying to teach so we manage those expectations, teach it, and then test that we've taught it. In 2014, we implemented that intervention, and we had a little bit better outcome. So we feel now that we're on the right track as to what we should be doing, but we're continually refining. In 2014, we started a program that would change the autopsy to an integrated autopsy. That is, the AP and CP resident have to work together to do a postmortem exam and write a comprehensive opinion. The AP resident is the one who's writing it, but the two have to work together. I can tell you that this works extremely well when there's an interesting case. The problem is when it's sort of a routine case, getting people to interact and work together. It's mandated, and we're making progress going towards 100%, but I would say that you really have to force the issue because it's not easy when it's just a routine and straightforward case that doesn't seem to be complicated. In the complicated cases, of course, not only the residents working together, but faculty work together, and it really makes for an interesting case conference discussion. So what's next? Those of you who are familiar with the series of studies that Stan Roboy pushed forward on workforce know that in the first paper, we projected that in 2030, there would be a decrease of about 5,000 pathologists. That is, this is a forecast, not a prediction. It's a situation where pathologists are an older population, and that unless some of us plan to work well into our 90s, like Dr. Koss, the likelihood is that most people are going to retire or die, and the number of pathologists we're training versus the number that will be retiring or out of practice it's not enough to keep up, basically. So the curve's going apart. 2014 was probably the worst year, and there will be more and more job opportunities. Unless we change the way we practice, that is the demand part of it, What we can see at 2030 is there'll be 5,000 fewer pathologists practicing than we have today, number one. Number two, the population is growing. People are living longer, and they're living longer with chronic diseases. So the acute care aspect of diagnostic medicine and the management of chronic diseases is going to require more diagnostic medicine, more pathologists, or a different way of practice, if you will. In this case, then, we'll probably go back to the way things were maybe decades ago, where our residents are going to be getting jobs straight out of residency. Right now, the average is the residents do 1.4 fellowships. I think one fellowship in the future is going to be maximal. So how do we change our training programs? How do we reduce time to competency? We're starting a new program this year that will have a 2-year core for AP-CP training. The 2-year core will be trying to accomplish what we did with the integrated autopsy, bringing AP and CP together. A natural model for that certainly is hematopathology. One can think about medical renal pathology as well. Certainly there are ideas, there are disciplines where we're going to have to teach basic knowledge in particular areas that may be in chemistry or microbiology or what have you, but we need to integrate as much as possible. You can't integrate unless you provide a foundation of knowledge. So we'll have to provide the foundation of knowledge and the skill sets and take every opportunity we can to make sure that, that the process of coming to a diagnosis is what we emphasize, and that the residents learn how to use all the data available to them to put that information together to render a diagnostic opinion. We have to stress clinical reasoning, clinical decision making, and the use of data analytics and computational pathology. What will this do? This will begin to answer the many surveys over the last few decades from community hospital pathologists that say that our trainees are lacking in particular areas. One area is adaptability. That is, if you look at the numbers today, approximately 40% of pathologists practice in groups of 5 pathologists or less. So that means that if you're in a group like that, not in the academic settings that we practice in, you're going to have to be adaptable. If you've been trained for many, many years as a GI pathologist and you go to a group like that and they need someone to cover basic GYN pathology, you're going to be marketable if you can do that. If you're so focused in one area that you can only do one thing, you're not going to be marketable. And now you can say, well, things are changing and maybe those practices won't exist anymore. I don't think that's true. I think as systems grow, there still will be community hospitals and practices like that. Some modifications, but not total. People with good work ethics, people who are agreeable, can interact in a team-based way. We need to continue to train our residents to be presenting, to be interacting with other physician colleagues. So we also need to give them confidence. We need to give them independence, which means we need to develop rotations where they can act independently at an earlier stage of their training. I would suggest, and these are concepts now, we're not there yet, that the 3rd year increases graduated responsibility. A going-in thought that I have, but we're still in discussion because we're just starting year 1 at day 1, July 1st, would be to have 6 months in an AP dedicated and 6 months in a CP dedicated, if you will, where different skill sets are learned, lab management type skill sets, integrated practice skill sets, et cetera, but where the resident becomes more and more active and more independent. And then to me, the 4th year should be a fellowship year. It should be a year that we have right now. It's called a fellowship. That should be in the 4th year. So if you think about our staffing, some programs use residents to replace staff that would be technicians or PAs. We're not training them to do that, right? We're training them to be professionals and colleagues. So we need to staff properly so that we can start their independent training as a professional earlier, so that in the third and the fourth year they can become more active and relieve more of our work as a professional than they would relieving the work of a tech or a PA. So that's our concept going into that. Have me back in 10 years, I'll let you know how it worked out. Year one starts in July 1st. I must say the one comforting thing is that the faculty are actually quite engaged in developing this program. It's not being handed down saying you have to do it this way. They're very engaged in developing it. Either that or no one's talking to me, I don't know. Both are viable options. Okay. So let me move on to the second topic, which is my role in CAP in education of pathologists. There are two areas I want to discuss: resident education and practicing pathologist education. The CAP has some limited resident education, and we can do more, but I would need feedback from you all as to what areas we should focus on. And I'm going to talk about the overall educational programs, give you an overview. On the resident side, CAP partnered with API and APC to develop the peer curriculum. That's a pathology informatics education in residency. And that's a guideline that I think about a dozen schools or programs are using it through a beta test site, and it's still being rolled. But the curriculum in the program is available to everyone, and you can pick. We've picked parts of it to use in our own program. The test utilization for residents. This was a free course that was developed with CAP and APC based on with 10 cases, and I'll go through that in more detail later. CAP has almost 300 educational programs with CME and SAMS, especially with a special focus now going towards maintenance of certification. There are a variety of programs. There are online programs with capstone events like the AP3 program. There are learning series that are webinars. We're trying to develop programs that most people basically want to have their education on something like this. And we're working very hard. We're not there yet. The CAP website needs work. The learning management system's new. But we're trying to develop things that will make the learning you need accessible to you in the way that you want it. The annual meeting has over 90 courses. There's case-based learning like CPIPs that I'm sure you're familiar with, journal-based learning, webinars, etc. So the CAP APC test utilization, I'm just going to show you the screenshots from this. This was a program that was designed to teach test utilization, but to teach the professional interaction, not only knowledge, but the professional interaction between the pathologist and I'll call it the requesting physician. I know that the rest of the medical community calls it the ordering physician, but we like to look at it as the requesting physician. These are the course objectives, and since I'm tethered and my eyes aren't that good, I can't actually read them, but you see what they are. We tied it to the residency competencies and milestones. So this satisfies the milestones and competencies on system-based practice, professional interaction, patient care, communication, etc. Here are the 10 cases. Many of them were written and developed by both residents and faculty working together. In summary, in these cases are free. The only difficult thing about this program is going through the CAP website to actually find where it is, but we've sent out to the residents a link so that with one click you should be able to get there, and if anybody wants that, we can help you get there. It's free, and it satisfies many of the milestone requirements. It teaches knowledge, practice, and professionalism. For maintenance of certification, So we look at education. Now we've moved from the residence to new in practice. The maintenance of certification in new in practice is growing every year. Some of us don't have to take the exam again to maintain our certification. Many others do, and it'll be 100% in time. So how do we make that easy for you? What we're trying to do at CAP is basically develop a concierge service that will give you a profile this is for the future. We're not there yet. As Amazon would. We know which courses that you take, make you aware of other courses. They may be CAP courses, they may be courses from other organizations that will satisfy your needs. We're building links between CAP and American Board of Pathology so that your transcripts and validation of taking and completing the CMEs and the SAMs will be transferred over to the board to make it easy for you. These are all things that are in process. So a little more than a year ago, one of the requirements was for patient safety. There was a long patient safety course that was offered by other organizations that really wasn't pathology specific. And basically, CAP responded by developing a patient safety course by pathologists for pathologists. It has learning objectives. It meets the CME and SAM criteria in terms of process, with pre-tests, going through post-tests and evaluations. It covers, these are screenshots from the course, all of the different factors that are involved in patient safety and diagnostic errors. It is a case-based course, and it presents with this 45-year-old woman, et cetera. It shows a dialogue like the test utilization between the pathologist and the requesting physician. It talks about adverse events and how they can happen. It talks about all the resources that you should consider in a healthcare system. It talks about the importance of communication, has some exercises in it, failure modes and effects it covers. And then the module basically gives you the proper credit that you need for the American Board of Pathology in patient safety from a pathologist's perspective. We did this in response to a request from pathologists that the other course that was offered was not good and not relevant for pathologists, and that it would be a lot nicer if we had a course that gave CME and SAM credit that was oriented to what we really do. So I use this then to make you aware of it, and within the first 2 months, 170 people signed up and took the course. I use this, though, as an example that if you have ideas, please let me know. Let me know where the gaps are in your education. Let me know what we can do better at CAP to make it easier for you to fulfill requirements for maintenance of certification. On to the learning objectives, the medical school education, the part that Mara was involved in this work. Several years ago, we were going through another cycle of curricular change in medical school. It's just really fortunate as to how intelligent and bright our medical students are that they manage to learn in spite of what we do to the curriculum. So we went through yet another change. And is a hook coming out? We went through another change, and the course directors at an APC meeting several years ago said, we're losing contact hours. They want to wipe out all pathology teaching. So the question is, do we look at this as a disaster, or do we look at it as an opportunity? And what could we provide from the APC, from UMEDS and UME, that would set national standards, basically, of what every medical student should be exposed to. So we embarked on this competency learning objective project. And we wrote a paper on national standards. 60 pathologists around the country contributed to that. And you can go to the APC website and use this information for free. We basically had people work in particular areas of their expertise. We then hired an individual who was skilled in the art of writing learning objectives so that it put it all in one voice. And we focused on 3 areas: disease mechanisms, organ system pathology, and diagnostic medicine. Now, in the standard old routine medical school curriculum, disease mechanisms and organ system pathology you're all very familiar with, taught in a very standard way. So what we had here is we had the competencies and we had goals, learning objectives, etc. Disease mechanisms, hardly ever taught, occasionally taught as an elective in the first year. This was meant to be of value at each individual's institution, to be able to pull out to the medical school deans in education and say, there are national standards, this is what should be taught. We did not prescribe who should teach it. I think that's for us to decide where we want to teach and where we want to be in education and where we want our medical students to see us as experts in diagnostic medicine. That's where we should be focused. But we said this is what should be taught. So we had these 3 areas. Then Don Regula helped us develop a wiki site. This is progressing, and in fact, APC will develop its own site, I believe in collaboration with Sage, who's the publisher for the new journal Academic Pathology. And I'll tell you more about that in a minute. So these sites have competency, they have goals, they have learning objectives, they have cases associated with the learning objectives. And we have about 15 to 20 cases now that have been contributed. These cases are reviewed, and so they can be put on someone's bibliography, they can count as clinical scholarship, and they can be cited. We can put in not only the questions, we can put in images, we can put in videos, whatever we wish. I will say that what we're working towards is a rigorous structure for these cases and for the review. They'll be published in Academic Pathology. This will happen in 2016. So there'll be real citations, okay, for clinical scholarship. In addition, we hope to be able to track how often the cases are open. So when someone who is a clinical educator or a resident is helping to develop these, and these are cases that you see every day, that you do every day, that can be attached to one of the learning objectives. So please help and contribute them. We'll be able to track. So it may be you contribute a case and maybe you're the only one that opens it. It may be that you because this is all free and online. It may be you contribute a case and 10,000 people open it. Well, that gives some credibility then as to how important that is. Okay? It may not be the most important scientific discovery in the world, but if 10,000 people are opening your case and using it to teach, I think it has a high level of importance. So then the same thing in organ system pathology, the same thing in diagnostic medicine. It's an area, the area of diagnostic medicine is really where we need to be. We need to be touching every medical student, and they need to see us as these experts, as the go-to people. It's where we're going to have our value as part of an integrated healthcare team, that we are helping them select the best tests, we're helping them interpret the tests so that the proper diagnosis can be made, proper treatment plan can be made. We're helping them evaluate the data to develop longitudinal cohorts and studies for evidence-based medicine. Okay, so I think I've summarized and told you all of this. Anyone who wants to submit a case, just write to me and we'll help get you started. So in summary, these are the educational objectives I have, and I think I've covered them all. Thank you for your attention, and I'm happy to take any questions.
So we have microphones. So if you could wait for the microphone.
So if I may start,
In the table you showed with your boot camp pre and post test, you had residents from 6 years. So are all the residents taking the boot camp on a yearly basis?
No.
So how are those data, in terms of?
That was resident number 1, resident number 2.
Oh, okay. Those are not
Those are
residency
6,
years.
yeah. We try not to keep the residents for 6 years.
So I think you explained very nicely how you went into a more integrated and contextual learning. So I was wondering how long this process took, and also if you have any resistance in the change from both parts, from teachers and from students or from residents.
So our first, several years ago, we thought we were doing a more integrated curriculum when we taught a little bit of CP and a little bit of AP in the first year, and we flip-flop back and forth. We clearly realized that that really wasn't integrating, right? I would say it was 2013 or so, maybe 12, where we started the integrated autopsy, okay? Certainly on hematopathology, that's always been an integrated rotation. Is there resistance? There's always resistance, okay? The question is how much, and I think that if we had tried to implement across the board when we implemented the integrated autopsy, we would have failed. It would have been too much too fast. Okay, but getting the residents to work together, getting the faculty to work together has been a major plus, and I think they've seen that as a positive. It's sort of similar to the situation with simulations. I've been pushing for simulations to be done in a more rigorous way, and the faculty tell me, well, Mike, we do that every day. That's what we do in sign-out. That's what we do in case scenarios. And my response is, no, you don't. Because you got a whole stack of slides to get through. You ask a couple questions. You're not going to wait for half an hour for an answer to take someone through a process to teach how to make a diagnosis. You're going to take it so far, and then you're going to give the answer and move on to the next case. So I think the question is, how do we develop these exercises so we really ingrain the clinical reasoning and clinical decision making? How do we make the effort, basically, that we make the residents go through a process so that by the end of the second year, that process is well ingrained? Even if they don't have subject matter expertise in one area versus another, they will be able to develop it. Just like all of us who have had to pick up some other area of practice that we didn't fully intend to do initially. We have the skill sets ingrained in us to learn how to do that. And I think that as we have small successes, the faculty and the residents see those successes. The other thing we do is we teach the residents how to present. And we videotape them like this is being videotaped. And we give them a USB stick, and they can talk about anything. One of our residents makes cheese. That's what he talked about. One talked about wine. One talked about, what was it? Street heroes of Puerto Rico, okay? And the idea is presentation skill, How do you make eye contact and connect with the audience? Am I giving my talk looking like this the whole time? Or am I talking to the audience? Am I connecting with the audience? And we give them this, and then they can see themselves and see what they're doing. How do you define or make a talk for your audience? When you present a tumor board, if you're an anatomic pathologist, do you start by giving the diagnosis, or do you start by describing the nucleus? When you're in a pathology conference and you're a trainee, do you start with the nucleus and then show how your thought process came to a diagnosis, or do you start just by giving the answer? When I teach medical students and I show them some histopathology, I'll ask them, what do they see? If they give me the answer, I know that they're not telling me what they see, they're telling me what they think they see. You know? So I want people to think, basically, and learn how to think. Personally, I have a vested interest in that. The older I get, the more likely I become a patient. I don't want to go to some of those people. So it takes time. I would say if you start slowly and have successes, it'll work. And the one thing I would say is I do try and avoid mutinies. So, yes, sir.
Thanks very much for a great talk. My question was relating to the fact that Montefiore is a bit ahead of UW Medicine in terms of expanding to more sites. Do you utilize all the sites, the different hospitals, laboratories that you have for your residents, and are there benefits or challenges to doing that?
No, Jeff, and thanks for that question. We may be more similar than you think because our relationships with the extra 5, 6 hospitals are some we own, some we're friendly parents, some we have different relationships. But even when we're fully engaged and running laboratory services, AP and CP for all of them as a unit, we'll only have training in 2 or 3 hospitals likely. And so then we have to figure out what we're training and how we're training. So this integrated process, if we haven't gotten there yet, but we had a building planned, we owned, but got slowed up a little in filling it out. If most of the faculty and residents are at that building, okay, they're not going to be frozen sections. So then they're going to be frozen sections at one of the hospitals. So we have to, I think, define what we want to teach and where it can be learned best, and then craft those rotations. But the short answer is limited sites for training. You can't put people everywhere. And I think you have to keep the cohorts. You have to keep residents together. You can't, unless you want them to act independently and run a particular site. If that's in the 4th year and you really want that graduate experience, then I think that's fine. Just put them somewhere and give them a lifeline. Okay, thank you.